Welcome to Good Medicine, a podcast about the ideas, people, and conversations shaping the future of healthcare. I'm your host, Dr. Rohan Ramakrishna, neurosurgeon and co-founder of Rune. Each episode, we explore how medicine is evolving through honest conversations with leaders and changemakers. Good Medicine is brought to you by Rune, the digital home for doctors. We're a free, physicians-only community to connect, share knowledge, and shape the future of medicine. I recently sat down with Dr. Bobby Mukkamala, head and neck surgeon, longtime Flint, Michigan physician, and president-elect of the American Medical Association, who just months ago became a patient himself after he was diagnosed with a left-sided brain tumor. We talked about what it's like to see your own MRI and move from shock to plan, and how bringing family into every critical visit should be the standard of care, and what his lived experience as a patient taught him about the healthcare system he's shaping as president of the AMA. A few things from our conversation really stuck with me. First, support isn't a nice to have. It's an actual clinical treatment. Bobby makes the powerful case for proactively inviting a patient's care circle into consultations, so facts aren't lost in the fog of a life-changing diagnosis. Second, risk is more than numbers. We discuss how a 1% complication rate lands very differently when you're the patient yourself, and why naming that emotional weight should change how we communicate risk. Third, if we want better outcomes, physicians have to play a larger role to help drive reforms. Whether it's indexing Medicare updates to account for increased practice costs, paying appropriately for preventive medical care, reducing administrative friction that fuels burnout, or even protecting NIH research, we have to all get involved if we're going to successfully grow and improve our healthcare system. Bobby brings candor, policy depth, and a lot of humanity. Let's dive in. So again, thank you so much. It's such a pleasure and honor to have you, Dr. Mukkamala, on Good Medicine. And, to jump right in, one of the things that was startling for me to read as a brain tumor neurosurgeon was that you were recently diagnosed with the glioma with symptoms that started during a speech. Can you walk us through that experience, what happened, what it was like?
Sure. Yeah. So I serve on the board of the American Medical Association and currently am president-elect. And so a lot of my schedule has to do with AMA meetings. And so here we are in Orlando, just this past November. So not even 6 months ago, really. And I was giving an update on AMA activities, a board update to an internal group, the Minority Affairs section. So a group that has seen me and known me for more than a decade. And so I'm up there and given my, 10-minute presentation. And in the middle of that presentation, I sort of had, what non-physicians would call kind of a brain fart moment, like, totally confused, off the right page of my script and comments. And any other audience that didn't know me would be like, oh, he just kind of lost his place and he's kind of a little confused. And within 60 seconds, I found the place where I should be and started to comment again. But this was a group that had seen me comment for years, and they were like, "Holy cow, Bobby just had a stroke," right? And so, one of the women stands up, and she's a senior member of the American Medical Association. She said, "I didn't understand anything you just said," and so here I am thinking that okay, I got caught, because in hindsight, that wasn't the first time that happened, right? There were maybe 2 or 3 presentations over the course of the past couple of years where I've had a similar moment, and I just thought that was aging. I'm 54 years old now, and I thought, okay, well, maybe this is just what happens to the brain over time. But immediately, my wife, who's an OBGYN, who was at the same meeting, gets a text message saying, I think Bobby had a stroke. And so she and the chair of our board find me after my next presentation, which went perfectly fine. And they say, "Don't move, we're coming to you." And so then they all kind of ended up right outside the conference room where I just stepped out from a decent update. And they said, "We think you had a stroke. You need to go to the emergency department." And of course, I felt fine, but it wasn't anything that was deniable. Clearly, there was an odd speaking moment there. And it turned out to be expressive aphasia in hindsight. But so I went to the emergency department and just wanted to make sure I wasn't having anything acute. all of the vital signs were totally fine. And they said, okay, well, maybe it was a TIA. Nothing more needs to be done while you're here because your vitals are stable. But as soon as you get home, get an MRI scan. So finished my meetings in Orlando, gave a few more speeches, and everything went fine. Got home to Flint, Michigan. And at 9 p.m., a neurosurgeon colleague of mine who has an MRI scanner at his office basically said, come on over, we'll get you scanned. And so because it was that hour, it was just me and it was the tech doing the MRI. And so I finished the MRI, and they didn't have a CD to put it on because the burner wasn't working right. And so I just took my phone out and I was taking pictures of each of the images just so I could look them over when I got home. Well, I had a sinus cyst that the tech pointed out, and she says, oh, you got a sinus cyst. And in my mind, I'm like, yeah, but there's a big ass tumor right there. And so I saw this left temporal lobe tumor, and then I knew that, there was a lot more going on than a stroke, a lot more serious stuff. And so, I called.
What was it like, by the way? I mean, I think I had this personal experience with my son. Thankfully, he's fine. But when he was a neonate, he had a seizure, and when he was like almost a month old, and when you go to the emergency room, everyone's like, lots of kids at this age have these things called funny looking movements or FLMs or something like this. I'm a doctor. I know what a seizure looks like. So I was like, no, I don't quite know. And then we get an MRI, and he had a stroke and a small hemorrhage, which apparently happens when kids he had like a respiratory infection or something. He was just, small. So no blood volume, whatever. Thankfully he was fine. But to see your own child's MRI scan and see that abnormality is, even as someone who sees MRIs every single day, hundreds of thousands of times by this point in my career, was still jarring. And so I'm wondering, when it's you looking at your own scan, what was that like, and how did you kind of process that?
It was oddly something that pretty much within a minute, I went from crap, the emotional response, to, okay, I need a plan, right? I need to figure out what the next step is. And so, I mean, it was, I guess it was kind of like, the Star Trek fans, it was like a Spock sort of response, right? Not emotional, but like, okay, what do we need to do? And so on the way out of the MRI scanner into my car, the neurosurgical colleague of mine, his office is just a 5-minute drive from my house. And so on the way home, I do a WhatsApp call to my dad, who's a retired radiologist, who happens to be in India right now and was back then. And I got him on the phone, and I sent him the pictures. And then he's like, let me call you back. And I thought maybe he was busy. Well, the reason he had to call me back is he's the one that was going through some emotional stuff. He saw the picture, he saw the name, and he was like, oh crap, my son's got a brain tumor. So then he called me back after about a minute of just sort of getting himself in order. And he was still on the phone when I got home. And it was exactly in this room on the screen that I called my wife into the room. I got both of my twin boys. They're 25 years old now. Got them both on the same WhatsApp call. And I just showed him, I told him what I had, and I showed him the picture. And, my mom was on the phone in India. My dad was on the phone, and they're all, just the complete sort of spectrum of responses that you would expect is what we got, right? My wife was crying. My mom was crying. My sons were like, WTF are you talking about? Thinking I was joking or something. And, again, my goal, and it was selfishness, but my goal was, okay, within a minute, let's just come up with a plan, right? What are we going to do next? And not have an hour or two or days of how did this happen to us? But instead, just acknowledge that, yep, this is bad news, but what are we going to do next, right? And again, it was selfishness and probably not the best thing. I remember my wife and my mom were incredibly emotional, and it should have been more acknowledging of what they were going through as opposed to what I wanted to see done. And that's a lesson learned.
Yeah. I have a very similar framework, which is solve the problem, rather than dwell on the emotional aspects of it. But I'm wondering, has that been for you in this process? Like how has that mentality and that framework worked for you? Has it worked well? And what lessons do you, having gone through this experience, have for others that might be navigating health challenges, as individual as they may be?
Yeah, it's gone well in that because I'm focused on what the next step is, there's not a delay in that next step. And that's for multiple reasons. Part of it is my focus, but that's a small part. Part of it is the fact that I'm a physician. I happen to be president-elect of the American Medical Association. We have a lot of colleagues that are in neurosurgery that know exactly about this type of tumor, a glioma, what it could be, looking at the radiology, what it most likely is, who are the dozen people in this country that do a lot of these that I should talk to about, is it okay to wait? Do I get a stereotactic biopsy, get the microscopic view of it, and then decide, is it urgent? Is it something emergent? Is it something I can wait on? Do I do the president of the AMA responsibility and then get the massive resection of it, or do I do this first? I mean, these are all legitimate questions, but that's kind of where my focus went. Is it a good thing? I mean, it's good for that reason, but it's bad because everybody else has to go into that mode also. And to my family, right, to any patient's family, it's devastating, right?
Yeah.
The odds of, I mean, my 25-year-old twin boys looking at the potential that they may lose their dad in a months or years, depending on what the final result was, but you just don't know at that point.
Yeah.
And, I mean, and then, a spouse, a wife, thinking that she may lose her husband and then figure out what to do, just the emotional response, but then the practical response, and not pausing to acknowledge other people's response and what they're going through, even though it's different than mine, I think is a lesson that I've learned.
Yeah. I'm wondering, I think I read somewhere said that initially this diagnosis feels like the worst moment in your life, but oddly became something else for you. And I'm wondering if, like, not the best moment, but like great learnings from it. I'm curious, can you dive into that more?
Yeah, I mean, I would say it did turn into some of the best moments of my life. I mean, literally, it went from a day or two of the bottom of my life, right? Like, okay, well, now instead of living till I'm 80 or 90, I may not even see 55, right? I'm 54 now. Was devastating. But the other thing we decided is that at that moment, and I think a lot of people go through this for any diagnosis, right? Whether that's a hernia or her brain cancer, whether or not it's going to be something that your friends know, right? Is this something we're going to share, or is this something we're just going to kind of keep close to home? And I made a decision early on, like at the very beginning, that, you know what? I have way too much going on to try to keep track of who knows that I've got this and who doesn't know. Who do we tell? Who do we not tell? And so basically, anybody that wanted to know, I mean, the local news found out about it. And I did a news thing. The American Medical Association put out a press release saying that the president-elect of the American Medical Association has a brain tumor. And so it became public knowledge. And the consequence of that was this phenomenal expression of love. I mean, just everybody, people I knew a little bit, people I didn't know at all of them, cards. And I mean, we have thousands of people that meet on a twice a year minimum basis at the American Medical Association. People that, I mean, have elected me as president-elect, and that was phenomenal as well. But now they're looking out for my life, right? And they're expressing their love. And that's something that was amazing. So again, it went from that bottom experience to within a matter of just a few days, going from the best moments of my life, just feeling that, right? And then also becoming very comfortable saying, you know what? I was the kind of person that just wouldn't express that sort of sentiment or love of people, even family, unless it was a special moment or something like that, or an emotional moment for some reason. But knowing that, okay, well, I might not be around for more than a year, guys, and I'm not gonna hide that anymore. So even my fellow board members, right? We had a Zoom call, and we told the people on the board about my brain tumor that was likely potentially something that I might be gone in a year. And watching their tears on the Zoom call made me realize the love that I had felt, right? And again, that never comes up in a board Zoom call. Right.
Yeah.
I mean, when you're talking about all these things and you're head to head on some issues, but knowing that underneath all of that we love each other was an amazing realization. And so the glass was definitely half full from that point on, as opposed to half empty.
Yeah. I'm curious, as a being on the flip side of the provider-patient experience.
Mhm.
What was something that surprised you as you went through it, whether on the surgery side or recovery side or hospitalization side? Was there something that you were actually genuinely surprised about?
Yeah, I guess so. I'm being a physician myself, being a surgeon myself, doing head and neck surgery. Used to do a lot more cancer surgery before the AMA schedule started to pick up and that sort of thing. One of the things I realized is that when I diagnose somebody with larynx cancer, right, it's just something that, I see the scan, I tell them what's going on, I schedule a biopsy, I do the biopsy, I get the biopsy results, and then I go over them with the patient. And at that time, whoever came to the office for the pathology results or was on the Zoom call or phone call about the pathology results, it never even occurred to me to question, why isn't this person on this call, or why isn't this person in this office, right? Even if it was just the individual patient, and that's who I was explaining their larynx cancer to. That's just what I did. It never even occurred to me anything otherwise. But now being on the patient side of it, right, and going to the Mayo Clinic with my mom, my dad, both of my kids, and my wife, all in every single room where everybody is taking notes and interacting with the surgeon, including the patient, or the neurologist or anesthesia or anybody, that was a phenomenal experience. And yet here I am not doing anything to encourage that experience. It's not that I would have said no, but I never even asked my patients about, do you want to call anybody? Do you want to put anybody on a video call? I know you might be, by yourself, but you got any family out of town that wants to participate in this visit? Because it's so easy to just put them on a Zoom call, turn it on so that they can watch me watch me talk about the pathology. So you have at least one other person, because the shock of being the patient that gets told they had cancer eliminates so much ability to just get the facts, right, and the logic, and be like, okay, this is why radiation is important, or this is why surgery would be the best option, while you're just processing what you just heard 2 minutes ago, right?
Yeah.
It's just too much to ask.
Yeah.
And so what I realized is that, the patient having support of their family is something that I, as a physician, never thought about, but now absolutely it's standard.
That resonates a lot with me. I think I'm a cancer surgeon as well.
Mm-hmm.
I just do gliomas and skull-based tumors. And early in my career, I would never ask that question about the family or support network. And now it's one of my first questions, because what you realize over time is that the families or patients that have large, or not just large, but like strong support networks, it might just be one person.
Yep.
Have a just different life experience with cancer than people who don't. And I think if you can bring as much and encourage as much of that community around a person, we call it, care circle, around somebody, the better off that patient will be. So I totally agree with you.
Yeah. I mean, I think just overall health, I mean, I don't know for sure, but I would bet that there is science that when not just the biology goes well, but the support also goes well, that the overall healing, the overall health, the future of this patient is going to be better when they have that kind of support. Yeah.
Yeah. I'm wondering, on the flip side of that question is, what aspects of the healthcare system did you find genuinely appalling, as a patient, or, things that made you reflect?
Yeah, I mean, the reality is, and this is something that the American Medical Association and I, as its president-elect, every time we're at a microphone, these are the things we bring up. Is as it is, to find out that I got an MRI scan within hours of needing it, and then I got all these consultations. I had an amazing experience, but the standard experience is waiting a while for an MRI scan, prior authorization. Right. Whenever that happens, it happens. And then getting a reading on that. And radiology is pushed so hard now that sometimes those readings, we routinely used to get, within hours, at most a day, a reading on any sort of image. Now radiology is so overloaded with not enough people that it takes days to get a reading. So prior authorization, workforce shortage, and then, getting an appointment in your area, hopefully, with somebody that can at least tell you what the options are. Just a plan is something that is so slow to develop. And so I had a unique positive experience, but I am no fool to think that that's a standard, right? I mean, that is a top experience. But if I lived in the house that's next to me over this way, or the house that's next to me over this way, I would still be waiting. I wouldn't have had my surgery yet, let alone an MRI scan, a consultation with a few different opinions, and then me picking, who I got along with best, that we sort of aligned with what my goals were and what their plan was. That is not something that is a standard. And so when I think about our country and what we spend on healthcare, right? And yet among developed countries where we rank as it relates to healthcare, and not just brain cancer, right? I mean, just something as simple as hypertension and diabetes. We're at the bottom of that list, right? We do an amazing job with brain cancer, right? I mean, that's why people come to this country from around the world for things like that. But nobody comes to this country to figure out if they have diabetes and what they're going to do about it, right? Or they're pre-diabetic, or if they have some stage 1 hypertension and need to do something about it. Those are the people that are the most disadvantaged. A pregnant person on the south side of Chicago, right? What they have to do to get obstetric care to deliver a kid is get on a bus and go to the Loop, which is where most of the OBGYN care is, right? I mean, it's just, there's so many headwinds as it relates to healthcare that I've learned a lot about with this experience. And if anything, it informs me better as I'm about to become president of the American Medical Association just in a few months in June, to have a lifelong experience as a physician. And then the last 6 months before becoming president, that of a patient, I think is just a wonderful prep for advocating for patient care and advocating for physicians' role in that patient care. Not some big corporate entity, not some CEO of some company that has a different motivation than optimizing patient care or even preventing disease in patients. When I think about the roles of hospitals and pharmaceutical companies and things like that, sure, there's absolutely a role for both of them, right? I need a medicine for the 10% residual brain tumor to not grow, right? Mm-hmm. But what about prevention of disease? Right? Which of any of those entities are motivated to encourage a healthy diet and exercise to prevent prediabetes from turning into diabetes? Nobody is incentivized to do that. And what's the consequence? Crap numbers as it relates to other countries. And that's what we really need to focus on.
Yeah. My last question about this before we get more into the MA, I'm curious, how did you think about risk? And I think about this from the standpoint of a surgeon, where you talk to a patient about a procedure, and I talk to patients about brain tumors all the time and the risks associated with it. And I'll tell them numbers based on my own practice. The risk of X is less than 1%, and et cetera, et cetera, et cetera. But if you're on the other side as a patient, it feels different, right? It must feel different. And so I'm curious, how did this experience influence how you might talk about risk in your own practice?
Yeah, I don't think that the numbers are the numbers.
Yeah.
But conveying those numbers, I think I will do differently, right? Before, like when I take out some kids' tonsils, right? 5% chance of bleeding, couple of percent chance of needing to actually go back to the operating room because of that bleeding and what that's like. And it's, when I think about that, it's a pretty low risk and it's not dangerous or life-threatening. And that's why I just don't want them to vacation in the Upper Peninsula of Michigan for at least 2 weeks after they get that operation done, so I can minimize anything bad happening with those few percent. But then hearing from the patient perspective, as you mentioned, that, okay, there's a 1% risk of death, 10% risk of communication issues, speech issues, and all sorts of other sort of potential complications / normal healing that can take a year to recover. But 1%, well, when I say 5%, I think that's a pretty low number. 1% is even lower. But thinking about, okay, well, this is a surgeon that does 200 of these a year, right? That means a couple of patients don't make it, right? And here I am, in December, and maybe I'm one of those two, right? And so while it's such a small number, and mathematically, it's nothing that would worry me when I deliver that, because we do our best, and with good training, it's even less than that. and then certainly I was in good hands there. It's not something that can be just mentioned as a statistic or a fact without acknowledging what the emotional response to that is going to be.
Mm, yeah. I'm curious, what drew you to ENT?
So I went to school at the University of Michigan and met my wife Nita, whose desk is right behind us there, and we were in one of those 7-year programs where you go straight through and you're guaranteed the medical school seat right out of high school, and that's all my parents wanted for me. And they said,
Yeah. My parents definitely wanted that too. The
yeah,
guaranteed
yeah,
school right away. Yeah.
exactly. So thankfully I was in that program, and our colleague Sanjay Gupta was a year ahead of me at the same program at the University of Michigan, and so that's where I was, and I was rotating through everything, and I really liked cardiac surgery. Right. I mean, I did a couple of rotations, one at the VA, one at the main hospital, with people that were just excellent at what they did, and just the precision of it was something that I wanted to do. So all the way through my third year, it was going to be cardiothoracic surgery. And in fact, Greenfield. So the Greenfield filter was something that you put in the vena cava to prevent clots. So he was our chair of surgery. And so he was going to write my recommendation letter so I could match and pursue cardiothoracic surgery. Well, then at the very end of my third year, I did an ENT rotation and fell in love with it because it was surgery, but it wasn't a certain age population, right? It was everyone from a newborn kid to a senior citizen and everything in between, both genders. And it wasn't all operating room or all office. It was, Monday, Wednesday, Friday in the office, and Tuesday, Thursday in surgery, which is what I do now. And it was just the blend that just really got my attention. And so at the very end of my third year, I changed my mind. Dr. Greenfield was very irritated and was not happy that I changed my mind. But so anyway, I matched an ENT because of that reason, and absolutely no regrets. I love it. Not in the smallest reason that is still wonderful is that it has flexibility in it, right? I used to do big head and neck cases in the beginning part of my practice. Now that I'm on the road for 100 and next year 200 days traveling, I can just stick to simple things, not have to close anything, not have my practice sort of fall apart because I'm on the road traveling so much. I'm in solo practice. I take all my own phone calls. So when I'm in Washington, D.C. tomorrow and I get a phone call from a patient, I'll get a message and I'll return it eventually. But it's not urgent, not emergent, like a head and neck cancer bleed or a tracheostomy bleed would be. And so it's the flexibility that I'm also enjoying at this phase of my career.
Yeah, that's great. I'm curious, what's astounding to me is what you just said, right? You're on the road 100, 200 days a year. How do you maintain a practice like that? That must be extraordinarily difficult.
Yeah, it's something that, this year as president-elect is 100, 110 days a year on the road. And I started to prepare my patients, letting them know leading into June, which is when I become president and spend 200 plus days a year on the road, that, hey, look, right now, if you have a plugged ear and you have earwax, usually I can get you in within 10 days, right? That's my standard goal. And it's going to end up being a month or maybe more when I'm busy with this. And there's a few patients that present with a little bit of irritation, but the vast majority are totally understanding and actually excited that the guy that cleans out their earwax is going to end up as president of the American Medical Association. I'm not out golfing, right? That's not why I'm late and taking a while to see them. They're very excited about that because I'm a guy from Flint, Michigan, their hometown. Yeah. And so they're excited about it. And a year goes by fast, as anyone would tell you. And so then I'll be on the way down as past president. That's another 100 days a year traveling. And then they'll kick me out the back door with my suitcase and say, it was fun hanging out with you. You're done at the AMA. And so then I'll have all sorts of time.
Amazing. Well, you mentioned being back at Flint. I mean, obviously you grew up there, but you could have practiced anywhere. What drove you to come back home?
Yeah. Yep. So we did our residency. So Nita and I, at first she thought I was kind of an ass when we were freshmen at the Inaflex program in Michigan, but finally by the end, we were dating for a few years and we ended up both matching in Chicago. This was before you could couples match because ENT was early match at the time and OBGYN was regular match. But anyway, we matched in Chicago, and towards the end of residency, she would say, that I impregnated her with twins and dragged her back to Flint, Michigan. And but the main reason was that we wanted to be in private practice, managing our own practice, not being a junior partner for somebody. We had heard stories about how the partners just get worked, but somebody senior. And again, they're not all like that, but this is what we were kind of warned about. So we said, well, why not we set up our own practice? Luckily, we came back to a town where I knew some physicians. I mean, I knew 5 physicians right on day one. So I had a few patients starting on day one, as opposed to building it and waiting years for it to grow. We were both at full practice volume within a year. But I did tell her that, look, we'll go to Flint. We've got our grandparents that are there to take care of our newborn kids, our twins. If you don't like it after a year, I'm happy to move back to Chicago and we'll practice there or wherever you want. And here we are 25 years later, still in Flint, Michigan. So it worked out well.
I read, speaking of Flint, that you got very involved in the, lead crisis affecting the community. I'm curious, how did you get involved in that? Because that's not a natural, overlap with ENT. So is it just being a community advocate and being interested in community health? And how did you, and where did you feel like you had the best impact there?
Yeah, I think the initial reflection you mentioned, that it doesn't really seem to align with ENT, is totally reasonable, except when you think about a community, and now the community full of non-physicians is hearing about the science of the consequence of lead on the kids in the community. You don't need an otolaryngology residency or practice to talk about that, right? You just need a basic science medical school training to explain to people what lead does to somebody, and why it should be avoided, and why there should be testing, and what the consequences would be. And so I had a role to play at the Community Foundation of Greater Flint. I was past chair kind of right when this was happening. And now I'm on a committee that, because of the massive generosity of the entire country, if not the world, to Flint, Michigan, as we were dealing with kind of a man-made problem, right? I mean, there was chemical that could have been used to prevent the lead exposure that wasn't used, and the lead was exposed. Everyone was exposed, and there were potential health consequences. That there was a lot of contributions that came from around the country and the world to help manage that. What do we do with these kids that were exposed? And instead of testing each one of them to figure out whose lead level is high, who may need something, we said, you know what? These are kids that are challenged anyway, economically, family, education. There's so many headwinds in when you grow up in Flint. And now another headwind is lead exposure. Let's not just qualify somebody that meets this criteria when they have all these other challenges. Let's use these contributions to monitor and help them with their education from now until they're 18 years of age, right? If you're in utero at exposure, these funds last until that kid is 18 years old. And so we're still helping that. But we've replaced 90% of our lead pipes and decreased the risk, and then helping these kids. So it's come a nice way. But the role of a physician is partly for the science, and partly because this house is in Flint, Michigan. Nita knew that something wasn't right about that water as soon as she tasted it. She was like, this seems to have a lot of chlorine in it. And so we put a well in. I mean, luckily we have the resources to be able to do that. Most people in Flint, Michigan, they can't afford $5,000 to put a well in and be off the grid when it comes to water supply. They need help. And so as a neighbor, as a community member, that's the other role, not just the science in my background, but the fact that I know what my neighbors are going through.
Yeah. Well, I mean, that just speaks to your character, obviously, right? You don't have to do any of these things, but
well, I suck at golfing. And so if I'm not going to golf, I might as well do something that I enjoy, which is leaving the world better than I found it. My parents moved here from India. They're retired physicians. They did their residency at Hurley Hospital, which is where I operate every Thursday, which is literally a stone's throw in that direction. And I remember my mom would go to make her peds rounds, and I would play on the playground outside the hospital at age 5. And now every Thursday morning at 6:30 a.m., I walk into the same hospital, walk right by the same. Now the playground is the new emergency department, but I remember vividly when it was a playground. So this community, this country has been so amazing to my parents and their generation, that the least I could do is leave it better than I found it, right? To help move us a little more forward, just like my parents helped this community as well.
Yeah. As you think about the AMA. What are your top? I mean, I've read what you wrote in your, or you said in your speech when you um, took on being president. But I'm curious, what are your big priorities at the AMA that you'd love to see accomplished in that year?
Yeah, I think that just what I see about healthcare, part of it
Mm.
we discussed already, is just kind of where we rank in the
Mm.
world as it relates to healthcare relative to what we spend. And I think we spend so much where the physician-patient relationship isn't the focus. That really needs to change, right? And we have a physician shortage in this country, right? The fact that we're going to be 80,000 physicians short, if not more. And a lot of the states, almost half the states, are sort of solving that problem by having non-physicians take the role of physicians, right? Somebody with 600 hours of training doing everything that somebody with 10,000 hours of training would do as a physician. And that's just not a good solution to improve our healthcare. The fact that our life expectancy, I mean, some of this is COVID related, but our life expectancy is sort of evened out, right? It used to be going up all the time, and now it's leveled out. And I have to think that part of that is just access to care. You know, the fact that in my office, I used to see when I was starting my practice, maybe one patient a month, they would come from an urgent care because they were just between primary care docs. Now, just today in my office, when I finished, there were a dozen patients that came to see me as a specialist from an urgent care because they didn't have access to the PCP. The PCP was so busy that they couldn't get into the primary care physician, and they just needed something taken care of. But the majority of them come in with the wrong diagnosis of otitis media, because an urgent care is great if something is urgent. But, you know, 5 or 6 ear infections a year that aren't accurately diagnosed because it's a non-physician without the experience that's selling somebody that they need this antibiotic and go see an otolaryngologist. And meanwhile, it has nothing to do with their ears. That's just a failure as a country of that patient-physician relationship that would lead to a higher quality of care. And that's what I would like to change.
And so how do you want to go about doing that?
Yeah, I mean, I think, you know, for example, the physician shortage that we have is a big thing, right? That you know, we used to have 3 medical schools in Michigan. Now we have 6 or 7, but yet we don't have enough physicians because the narrow part of that funnel is the residency positions, right? Graduate medical education is not funded nearly enough to keep up with the fact that we're living longer than we did then. You know, that number got frozen in the 90s. Here we are 30 years later with a very similar number of residency positions. And that's a problem, right? And that leads to shortage. That leads to, instead of spending 20 minutes with each patient and getting compensated appropriately for it, now we're seeing twice that number of patients because otherwise we're going to be backed up for an extra month or two. People will be going to urgent cares as they are now. We are failing when it comes to taking care of patients. And so how do we want to do that? I think we need to increase the number of physicians and make sure that there's a team, right? Physicians can help, can be the resource for information so that other people on the team can help take care of those patients. So team-based care with a physician's assistant, not a physician's associate, but a physician assistant, right? Because the acronym has changed for their specialty now. They're physician associates. And I think that just leads to confusion. Nurse practitioners, right? Physicians' offices that have those folks in there to help do a much better job of taking care of patients than one that is practicing by themselves and trying to take care of all these people, but unable to. In other places where these people practice independently without the physician advice to do the good quality care. And so that's another thing, is the scope of practice issue. And then one of the main things that we're just constantly drowning in is what the compensation to take care of patients, right? So the Medicare, for example, everything is based on Medicare. There's Medicare, and then there's all the private insurances that base what they're going to be paying each physician for anything based on Medicare. Sometimes it's even lower than Medicare, right? It's like 90% of Medicare. Sometimes it's 110%, but everything is tied to Medicare. Medicare is different than the insurance in any given state because this is a government product that has to pass congressional budget every year. And the other interesting thing is that the path that payment to physicians goes through Medicare is totally different than what payment to hospitals go through Medicare. If a hospital cost goes up by 1.2%, they automatically get 1.2% more the next year. It always keeps up. When our cost, Nita and I's office, where the costs have gone up by almost 30% in the past 20 years, and yet our payment rate has gone up by only a few percent. So this actually drop in reimbursement, that's not great, right? That needs to change. And even something as simple as saying, okay, just like hospitals, if the cost to take care of a patient in your office goes up by 1.2%, we will increase our reimbursement by 1.2%. That's what I want to do, is I want to keep people out of the hospital, right? I don't want to pay better for when somebody has a heart attack and pay worse for the prevention of that heart attack, right? And how do we prevent the heart attack? We have a 20-minute conversation instead of a 5-minute conversation with somebody in the office about their prediabetes, about their hypertension, about their lack of exercise. That prevents disease. And right now that pays crap relative to when they get that disease. One thing I discovered was the lifestyle medicine aspect of healthcare. And so my plan last year was, I was really interested in it. And my traditional philosophy has always been, I don't want to talk about something that I don't understand, right? The fact that I chair the task force on pain care and substance use disorder for the American Medical Association, I didn't want to do that without understanding that. And so I got my X waiver to prescribe buprenorphine just to learn what that was like. But again, to that point, I wanted to learn about lifestyle medicine to see what it was like to help patients prevent disease. And so instead of just talking about it, I decided to get my boards in it. So I took that board exam in November. It happened to be literally a week after I got my diagnosis of brain cancer. But at that point, I figured, you know what? I can take this. This was a Saturday, one of those testing center exams right after Thanksgiving. And I was like, look, if I pass, it'll be fantastic. If I fail, it's totally understandable because I just got diagnosed with a brain cancer and I failed this board exam. Luckily, I passed. So now I'm board certified in lifestyle medicine. And I think that's critical to prevent disease. And I think that's where I would like to see us put more focus instead of having to go through congressional battles and fail like we did just a month ago, or within this month, about having another 2-point-some% decrease in Medicare payment. When the real way to take better care of patients is to keep that payment with our cost of doing that work, right? And that's the goal.
Yeah. I mean, do you feel like I'm sure that there's probably many Congress people who are sympathetic to doctors, right? Mm-hmm. And the incredible work that's done every day. Roon in so many ways is a love letter to medicine and to physicians, right? And the incredible things that they do, the uncompensated care they give, and I always tell anyone who listens that I think physicians sit at this amazing intersection of so many things. It's not just biology and medicine, but it's also economics and finance and law and, health justice and equity and all these other things that you have to navigate every single day as a physician. Mm-hmm. But there's no CPT code for that. And I wonder, do you find, what's your sense of how this is going to evolve, whether in the next year or 2 or 3, where it seems crazy that we have to fight this battle every so years to get diminishing rates, right? So I'm wondering, how do you see this evolving? Do you see a permanent replacement, like a new piece of legislation that's going to fix this problem?
Yep. So HR 2474 was our permanent fix to this problem that didn't get passed this year, right? And I think the reality is that what you just said about our perspective about healthcare and the critical aspect of healthcare is absolutely true. But when you try to express that to somebody who has other priorities also, like border control, right? Like taking people that are undocumented and moving them out of the country, or decreasing the expense that we have in our country overall as far as budget, right? These are also priorities. And they trump the priority of the health of this country, right? And it's not something that we talk about. It's not how we would look at it. And those are the people I think we need to convince and say, look, if our life expectancy in this country is stagnating because of a lack of investment in prevention of disease, sure, we may protect the border, we may do X, Y, and Z on your list, but people are dying sooner than they should, right? Or their disease is not being detected as soon as that should, right? Or the prior authorization for the medicine we know is better for them gets denied, and they're going to have to use this instead. These are all things that affect the quality of our health, which should be a different priority than the other things that they're putting on as something that is equal to this. And therefore, if we don't get this, we're not doing this, right? Healthcare shouldn't take a backseat to some of the things that they're make it take a backseat to.
Yeah. Obviously, I couldn't agree more. I wonder. I know another area that you're focused on is physician burnout, and I'm curious. As every physician every day, you think about the inbox you have in the EHR and the number, especially in academic medicine, the number of trainings you have to go through to regulatory oversight and compliance. I mean, the amount of clicking on a mouse that we do on a daily basis that has nothing to do with patient care seems it's exploded, right? And I think if you think of the things that patients really love, it's just sitting in front of a patient and taking care of them. The rest of it we could probably do without. So I'm curious, how do you view the world when it comes to physician burnout and what we can meaningfully do about it in the next period of time?
Yeah, I mean, it's a critical issue. It's one of our main priorities at the American Medical Association right now, because if we're going to be 80,000 to 100,000 physicians short because of just new people coming in, and then on top of that, we have people that are 54 that a generation ago, before we had all this stuff to deal with, would happily practice until age 75 or more because we loved it so much and enjoyed it. But now thinking about retiring at age 60. So not only there's not enough new ones coming in, there's ones that are in practice that are burning out because of all of those hassles that you mentioned, right? And that's also something that needs attention. And some of that focus is just helping us deal with these mental challenges, right? Whether that's mindfulness, whether that's something, that's all important. But it's equally important, if not more important, to solve the external factors that cause that burnout, right? The fact that I have to stare at a computer screen or come home and do 15 charts in my office because the electronic health record is so crappy that I can't efficiently do it. And those are things that we have to deal with, right? And those are the things that, I didn't go to medical school. None of us went to medical school to be typists. And yet the percentage of us that actually have somebody in the room to record while we're talking to the patient, doing what we are best at doing, is so minimal, right? We're the typist, and that's just wrong, right? And now there's technology, and there's always technology solutions. There's AI products you can buy that sort of, that listen and then create, and that's all good. But that has consequences also, right? The liability associated. What if it comes to the wrong conclusion? What if it types the wrong thing? What if the cost is so much that getting paid 2.8% less now, but yet you want me to upgrade my health record with some product to make my life easier when I can barely keep up with the inflation of the labor costs, right? The staff that my wife and I pay in our office, that when we started were at $10 an hour 25 years ago, and now at $23 an hour. And yet my payment has gone down since we started relative to that kind of inflation. Those are the things that make, I tell people it's kind of like Fred Flintstone and George Jetson living in the same time, right? Yeah. My wife does robotic uterus surgery as an OBGYN and then comes back to the office and faxes the op note, right? So doing cutting edge surgery and then using something from the 80s to communicate to the primary care physician because they happen to be on a different EHR and there's no compatibility, that's wrong, right? Yeah. And so we have a long way to go to make our ability to take better care of our patients and to improve that.
If you had to pick one or two things in physician burnout that if you could snap your finger and kind of deal with, what would those two things be?
Yeah. So I'm in private practice, and private practice is something that my mom was a retired private practice pediatrician, right? She had two people in her office and practiced complete enjoyment of that entire experience in this town from the 70s all the way to the 2000s, right? Just loved it. And then I look at my practice and I think about how much more difficult it is to run, right? And the fact that if I couldn't take it, right? If the math didn't work out, if it was just too stressful, if I burned out, I was just going to sell my practice to some massive institution, some university. All of a sudden the name changes, they run the office and I'm a pawn in their chess game as opposed to managing my own practice, right? That's what I want to focus on, is make us happy taking care of patients, whatever setting we choose. But private practice used to be 70% of the practices in this community when I started were private practice. Now it's more like 30, right? It's 70-30, but it's the different 70-30. right? And that's a failure. And we just need to have the patient-physician relationship be what drives all the decisions about healthcare, not some corporate entity that has different motivation to take care of sick people in the acute setting. And one of the other observations I've made is that 2 out of the 3 hospitals in my community have bought the practices of pretty much all their primary care physicians they could. In theory, it's because they wanted to help them take better care of their patients. The reality is they want all the referrals from those practices, right? Every cardiac test, every MRI scan, every single test that gets ordered, when you own the practice, goes to your institution. That's the motivation. And that kills private practice, right? And so the reason to do it has nothing to do with improving the trajectory of health in our country. It has to do with economics of these acquisitions of private practices. And that's something that I would love to see this truth go out there so that the communities and the lawmakers realize what we need to preserve if we truly want to improve the preventative health, let alone the health in general.
Private practice is my dad was in private practice as a pulmonologist in Scranton, Pennsylvania. And as you mentioned, when later in his career, the market forces were such, it was unsustainable in his practice environment to stay private.
Yep.
And so he joined a major medical, hospital group.
Yep.
But you can see what changed, right? When you join a big group, right? In terms of the personalization and the proactiveness that you can kind of do every day. And so I'm wondering in private practice. So I'm wondering, given the headwinds that private practices face, what is it going to take for private practice to reclaim some of that sort of market share?
Yeah. So one is resources, right? So just managing your practice. That's something that, if you're at a university, you can just call and somebody eventually looks into it and then we'll fix something, right? If something happens in our office, it comes to us to fix. And so resources where private practice can learn from private practices. The American Medical Association has amazing resources for private practice. In fact, it's now a section of our American Medical Association because it's a dying subset of physicians in this country as far as size. Those are resources that are critical to help private practices survive. And then the other thing is just something simple. When your dad sold that practice, right, from private practice to some university setting, payment for the exact same code went up, right? 99204 that he used to get, $75 for is now paying 115 because the sign on the door, the name changed, the site of service differential. That's just wrong, right? And the logic behind it was reasonable. When sick patients go to hospitals, they have to train, they need much more resources, therefore pay them more to take care of this. But when that same institution buys the practice out in suburbia just to take care of all the usual stuff that I'm taking care of, and because theirs says University of ... and mine just has my name, and there's a differential in payment, that's just wrong.
Yeah. I'm curious, shifting out of private practice, when you think of all the recent news around indirect cuts for universities and things like this that affect so many physician investigators out there, I'm curious, has the AMA waded into that, and does it plan to wade into that? And what's your, I think there's probably, everyone can agree there's always room to cut in a efficient way.
Yeah.
But how do we deal with this crisis? Columbia's has $400 million in frozen grants, much of which is in clinical research.
Yep.
This to me does not seem like an effective way to reduce spend. But I'm curious, what's your take, and what do you think the AMA is going to? How do you think the AMA is going to tackle this?
Yeah. So the AMA has already made statements about why this is a bad idea. Right. That we shouldn't approach. I understand the desire to have a more efficient government, but to use an axe instead of a scalpel is just foolish. And personally, this NIH grants change couldn't be more important to me as a patient. And the reason is the pill that I take, because I have grade 2 astrocytoma, is something that was just approved in August of this past year and Duke University did the research for a decade, more than a decade, and it finally got approved, and it was massively supported by NIH funding. Right? And I talked to the professor, the pathologist, that created this product to help keep this mutation in my astrocytoma from growing. And that was critical. And he couldn't have done it without NIH funding. It doesn't get any closer to me. And again, I'm just one person, but it's such a perfect example of why NIH funding, the way that it is critical to have the health outcomes that we want, right? We don't want people to die earlier because the research, I'd be dying earlier were it not for NIH funding. I guarantee it. And again, it's not about me, but you multiply that by our entire population and we fail even more in healthcare when we don't fund research appropriately.
Yeah. I wonder, the other, as you spoke, what occurred to me is that the AMA does some incredible work, right? And it's quite obvious that it does. I'm curious, one of the problems though is that in me in neurosurgery, I don't get really interact. I mean, this is my own foolishness maybe, but like with the AMA on a regular basis, I wonder how do we bridge that gap, right? So that everyday physicians who are practicing feel and understand, participate with the AMA. Like, I'm curious, what do you think explains that delta and how do we fix it?
Yeah, I would say that, so I got on Doximity, right? When I was recovering from my brain cancer and I couldn't work for 6 weeks. And I was like, you know what? My house has never been cleaner. Nothing has been ever running so well. And then finally, when all that was done, I still couldn't get back to work. I was like, let me check out this Doximity site. And so I see on there so many opinions about the American Medical Association that are not founded in fact. They're opinions. But yet I know, as a president-elect of this organization, all the things we've done, that the people that are sort of very insulting of the AMA because they're just not aware are typing. And so how do we bridge that gap? Well, a lot of them complain about all the mail they would get from the AMA. Right? We send a lot of mail. And it seems prehistoric, but yet that's how people, it's not emails get trashed immediately, paper mail at least might get read. And so there is a lot of communication. And yet it still doesn't close that gap that you're suggesting. The other way is membership, right? So when you are a member, there's all sorts of things you can click on that tie you to the aspect of what the AMA does that you want more information on. If your main thing is we just need to make sure we don't get cut by Medicare ever again, you can get updates every day about the work and the products and the comments that we make as it relates to that topic. If on the other hand, it's about medical education, right? And how we need to evolve medical education and make it more flexible and not be what I got when I graduated from Michigan in 1995. It needs to be very different now, right? And so that aspect, and the AMA has a lot of input into that aspect of medical education, that's also available. And so you can find any topic that you're interested in about healthcare in general, whether that be, physician burnout, mindfulness, solving the institutions where you work, the Joy in Medicine Awards that we give those institutions, to preserving telemedicine as a way that we get compensated to take care of patients, to preserving scope of practice where we can make sure that physicians are taking care of patients as part of the team as opposed to a non-physician team. Whatever it is that you're interested in, there's activity there. And so it's just a matter of exploring. And honestly, the reality that I find is that we have statistics that we represent, 20% of the physicians in this country. And so that means that, that 4 out of 5 don't join the AMA. But every time I go somewhere and give a live presentation to a room of 50 people in South Dakota, to a room of thousands of people in Washington, D.C., there is a almost unanimous comment that I didn't know the AMA did that, right? I'm so happy to hear that. And then maybe some of them will join. And so it's the in-person interaction that seems to do more than any piece of mail or any sort of communication to say, check our website. And that's just the reality of human interaction. And I'm happy that this brain cancer thing is not something that's going to get rid of me anytime soon. Therefore, I will be able to hit the road for 200 plus days and have that interaction and hopefully motivate people to get involved with an organization that helps them take better care of their patients.
I love that. All right. In our final minute, I just have some quick hit questions.
Sure.
Who's a mentor of yours that's really impacted you?
You know, my dad is a radiologist. He's retired. He used to be president of the Michigan State Medical Society. He was on a council at the American Medical Association as an IMG. That was almost unheard of, right? And there's never been an Indian president of the American Medical Association until my inauguration comes up in June. And so I feel, I mean, people comment that congratulations, you're the first Indian president, as if I accomplished something. My dad built the staircase, and I just happened to be on the top step of it because of the effort that he put in coming to this country at age 25, now almost being 80. It's because of his effort that I'm here.
And then last question, what do you want your legacy to be?
Well, I don't want anything to be tied to me, my name or anything like that. I guess I want my legacy to be motivating people to improve the world that they live in, right? Passive humanity is not something that appeals to me, right? I want to see people pursue what they love, whether that's painting a beautiful painting or whether that's improving people's health or whether that's being a wonderful parent. All of those things are equal in my mind, but let's express that by action.
Yeah. And then is Congressman Mukkamala, is that part of your future?
You know, it's funny. It did come up as an option soon after I got elected to the American Medical Association board. There was an opening in like 2017. And then I asked the AMA, I was like, hey, is this something I can do? And they're like, no, if you want to do that, you're off the board. And the board election at the AMA is something that an entire state, the Great Lakes Coalition said 2017 is the year Bobby Mukkamala is going to be president-elect or be the board member of the AMA. The last thing I wanted to do after years of effort and flagging me as that person was to say, hey, thanks, it's been a fun month, but I'm going to go run for Congress. That didn't happen. And now, honestly, my two choices when I'm done, and I think I'll still be alive with this thing, when I'm done at the AMA in a couple of years, what do I do? And one option is to, again, run for Congress and be a publicly elected person. The other thing is I have an alternate certification to teach. And we have a 4% college readiness rate upon graduation from Flint community schools. So in the city of Flint, if you want to go to college and go to college, 4% are ready for college. 96% have to take some remedial classes. So teaching math and science in our Flint Community High School is something that is also on my list. And honestly, is higher on the list than being an elected representative dealing with the stuff that happens in Washington, D.C. So that's where I'm headed.
Thanks for listening to Good Medicine, and a special thank you to Dr. Mukkamala for sharing his perspective. If you're a physician, we'd love for you to join the Roon community at roon.com. That's www.roon.com. You can also help us grow by sharing this podcast with a colleague or friend. Until next time, thanks for being part of the conversation.